As a starting point, maybe we all are on the same page to understand that this month marks cancer awareness, meaning this conversation is very timely in that regard. But today we'll especially focus on the psychological journey of cancer, whereby we are not just looking at cancer as a diagnosis or treatment when it comes to oncology care, but we will also look at remission because, we have to talk about the emotional and mental health aspects that we hardly ever talk about when it comes to the treatment of cancer. So cancer is defined to us as, or rather medically, it's defined to us as a disease in which some of the body cells grow uncontrollably and spread to other parts of the body. But as we said, our focus is not going to necessarily be on the diagnosis, but we are going to look at it at a human level, where cancer is an event that significantly disrupts the life of the patient, the relationships they have, their roles as human beings, as well as their identity. And that is why mental health becomes an essential part of this particular conversation. So we can start off with some statistics. So globally, or rather just to set the scene, in 2022, it's estimated that there were about 20 million new cancer cases and roughly 9.7 million deaths as a result of cancer. And here in Kenya at the moment, cancer has now become the third leading cause of death, with approximately 48,000 new cases and 33,000 deaths in the year 2022. So we also have to talk about the emotional toll that this causes to the person. As we said, we can always acknowledge that medication has progressed in this regard, whereby we have better diagnostics, we have better targeted therapies, we also have better survival outcomes in many cancer cases. But what often remains invisible is the toll that it takes on the mind of the person. So whereby we have to talk about the fear, the anxiety, the what ifs, so the unknowns that a person is going to experience. So one cancer patient puts it this way, where everyone asks them about their chemo journey, how treatment is taking them, but no one asks how they're sleeping, if they're still afraid, or how their mental health is doing. And that single statement speaks volumes. Many patients describe feeling like they live in two worlds. So there's one world that is filled with doctors, there's a lot of medication, there's a lot of scanning that happens. And then there's now the personal world where it is filled with a lot of fear, a lot of uncertainty, and the constant effort to remain strong. So what then becomes the mental health dimension of screening and diagnosis? So the screening process has been found to be emotionally charged, whereby there's a term that many patients use called anxiety. So it's just a combination of the scanning as well as anxiety, which just describes the tension, the sleeplessness, the dread that people feel when they are awaiting their results. So, and what are some of the symptoms that are related with this particular anxiety? So there's a lot of restlessness in patients, there's poor concentration levels, there's a lot of irritability, and some even report experiencing physical symptoms like fatigue as well as heart palpitations. So at a gender level, or rather if we're to narrow down and look at cancer treatment outcomes by gender, so for women, it was found that the fear of a positive result or even the changes in the body image after treatment could potentially lead to low self-esteem or even depression. And then for men, particularly who get diagnosed with prostate cancer, there has been reported issues of, questions about their masculinity, their sexual identity, which bring about feelings of shame, or even withdrawal that makes it difficult to reach out for help. So you find that for such symptoms, or in the event someone is at fear of maybe getting a positive cancer diagnosis, the anxiety sometimes is going to reduce the, when we look at statistics of, are people going to reach out for help in the event that they have a fear of getting a cancer diagnosis? So the shock and denial, as well as which is going to lead to fear and anxiety, will affect a person's treatment outcomes, whereby in the event a person is experiencing a lot of fear, they're not going to reach out for, for the assessments to be done in that particular instance. So the emotional trajectory of cancer will then move from, the shock and denial that a person is going to have. This happens at the moment, maybe they get the diagnosis, and that could transition to fear and anxiety about the treatment outcomes. We can all acknowledge that cancer is a chronic illness. And the thing about chronic illnesses is that treatment outcomes are unpredictable. It's very difficult to predict whether a person is going to completely get better. So, and that's why we also have to talk about remission, because even at a point where someone is going to go through the whole treatment process and they will get better and they get into remission where symptoms have been suppressed, there's always that lingering fear of recurrence, a reminder that, and this fear of recurrence is just a reminder that while physical healing might have taken place, the psychological recovery is going to take longer. So when we look at some statistics in connection between cancer and mental health, so studies show that around 25% and 50% of, between 25 to 50% of people living with cancer experience clinically experience clinically significant depression or anxiety. And now within the African context, you find that this particular statistic rises to over 53%, meaning more than half of our patients within the continent are silently struggling. And why is this link strong, you may ask? Because cancer is going to affect every dimension of a person's life. So the physical, the psychological, the social, or even the spiritual care. So let's take, for instance, depression. A newly diagnosed patient of cancer may begin grieving the life that they had before their diagnosis. So they might start experiencing symptoms of loss of interest in things that once brought them joy, or even withdraw from family because they feel like a burden. While anxiety, on the other hand, because this revolves around the uncertainty, they find themselves consistently asking questions of what if the treatment doesn't work? What if the cancer comes back? If it's a person who's in remission, if it's a person who has children, what will happen to my children if they don't make it? There's also the question of finances. So chemotherapy tends to be very expensive. Is this something that I can sustain moving forward? So, and these fears are not irrational. They're just a part of the human response to what is a life-threatening illness. But now we find that when they persist, they're going to interfere with recovery, their adherence to treatment, and overall, the quality of life. So when you find that when there's a lot of emotional distress that goes unnoticed or even untreated, it just does not affect a person's mood. It also affects their biology. So for instance, patients who are recently diagnosed, once they complete their chemotherapy and they get into remission where they're cancer-free, they find that every headache, every body ache is going to trigger a panic is going to trigger panic of, is this, are we having a relapse, or are we getting back into active treatment? So for such a person who is very panicky about any symptom that they get, you find that they are likely to avoid any oncology reviews that may be upcoming because it's too emotionally draining for such a person. And this just ties to what we just said, where that yes, the body is healing physically, but psychologically they are still struggling with what they're going through. So we also talked about the anxiety that comes from the scanning, where a person is going to lose sleep, they're going to have racing thoughts, or even experience irritability. And that's why it's important as practitioners, we have to ask ourselves, are we doing all that we can for our patients? So in the event that you are an attending physician, you're an attending nurse, or even a psychologist, what are we doing for our patients to ensure that we are covering the whole base, so that we're not just healing the physical, but also we are looking at the mental health aspect in that regard. So at this particular juncture, then I would like to hand it over to Linus, and then he can walk us through the screening as well as diagnosis.
Thank you, Vivian. Because of time, I'll go straight to my presentation. I will talk about the mental health, the screening and the diagnosis when it comes to the mental health dimension of cancer. For women, the fear of a positive result or changes to the body image after treatment can lead to low self-esteem, anxiety, or depression. Studies actually show that there's a higher prevalence of conditions like body dysmorphic disorder among individuals diagnosed with cancer. For men, prostate cancer screening and treatment may threaten masculinity and sexual identity, sometimes resulting in shame, withdrawal, or reluctance to seek mental support. And studies also show that patients who experience intense psychological distress while they're also diagnosed with cancer also tend to have much worse treatment outcomes than patients who have their mental health sorted. Let's talk about the emotional trajectory of cancer. Vivian already alluded to this. Shock and denial after diagnosis is often a common reaction. The Freudian explanation for denial is that denial is the defense mechanism that protects you from the anxiety that is associated with accepting reality. And the reality here is a diagnosis that oftentimes most people would fear. So it's not irrational as a reaction, but it's a reaction that oftentimes can lead patients to even refuse medical treatment, refuse the doctor's diagnosis, and not also follow the doctor's advice. And as you know, that can be quite detrimental. Fear and anxiety about pain, death, or finances, and taking care of a cancer patient can be quite financially intensive. Depression and hopelessness as treatment progresses. We've already talked about body image and identity issues after surgery. There's loss of hair. There's sometimes weight gain or weight loss. There's the thinning of hair of the skin. That's things that may trigger symptoms related to body dysmorphic disorder. There's also survivor's guilt or fear of recurrence post-treatment. Survivor's guilt is also often experienced by the survivors or the family members of the person suffering from cancer. Vivian already talked about that even after remission, many experience lingering distress and uncertainty, showing that psychological recovery often takes much longer time than physical healing. That even after a patient has gotten into remission, a significant portion of them will still experience like some level of psychological distress. So the burden of cancer is not only experienced by the patient, it's oftentimes also experienced by the family members of the person suffering from cancer. Cancer not only affects the patient, it also affects the family. And the burden or the anxiety and the fear and the pain that the family goes through oftentimes goes unnoticed. Caregivers, often spouses, children, or siblings, face immense emotional strain as they balance medical, financial, and personal responsibility, as well as the stigma that is associated with having a person at home who's diagnosed with cancer. Globally, studies show that 40 to 60% of caregivers or cancer patients experience clinically significant anxiety or depressive symptoms, and nearly 1 in 3 struggle with caregiver burnout. And a significant portion of this family members or significant others of people diagnosed with cancer will not receive a psychological diagnosis, will not receive a mental health diagnosis. So they suffer in silence and they don't get any kind of care. the caregiver's burden. In Kenya, caregivers often lack formal support systems. They're, they're not uh, required to see a psychologist, they're not taken to see a psychiatrist. Uh, Cultural expectations also push them away. The expectation for them to stay strong, for the family members who's been diagnosed with cancer, even when they suffer silently, only exacerbate their problems. Many report sleep problems, chronic fatigue, guilt, and helplessness, especially when watching a loved one in pain. And as if you read those symptoms, they do mimic symptoms of depression. So most of them, as Vivian has mentioned, would suffer depression and anxiety silently. Caregiver burnout not only harms their well-being, but can also affect the patient's emotional stability and care quality. So there's a lot of stigma surrounding cancer, especially here in Africa, and the stigma only acts as a barrier for them to receive potential, not just a treatment, physical treatment, but also psychological treatment. A common stigma is that cancer is a death sentence. Cancer is generally seen by the wider society as a terminal disease with no possibility of recovery. Although there's no single percentage for cancer recovery, overall, 5-year recovery rates have improved significantly, with a 5-year net survival rate of about 64% for all cancer cases combined. So treatment outcomes are improving. The science, the technology, and the medicine is improving. I think in the near future, we're probably not going to be talking about cancer as we talked about it for the last couple of decades, but it's still associated with death. It's still considered as a death sentence. Cancer is also considered something that spoils identity. The perception of cancer patients as being unable to participate in work or social life or go back to life as it was before the diagnosis oftentimes is very stigmatizing. So what's the impact of the stigma? Stigma related to cancer influences health-seeking behavior. People, when the more the stigma, the less likely that people will actually seek help, and it keeps people from getting suspicious symptoms checked by a medical profession, like lumps in the breast that can be detected early and treated before they become carcinogenic. So how do we address the stigma? We address the myths and the misconceptions that can promote stigma. We also need policy and pragmatic action toward reducing stigma. We also need to undertake advocacy for policies and address cancer stigma. We also need to integrate communication and share decision-making approaches into training. We also need to integrate stigma into national cancer control plan. We also need participatory research at community levels to shape the design and delivery of cancer intervention and address stigma in whole. Last and not least, um, we'll talk about integrating mental health in cancer care. So we need counseling and psychotherapy. CBT has been found effective not just for cancer but in mental health in general. It is the most evidence-based treatment modality in the world. It oftentimes can be effective for people who have cancer because they're also quite more likely to have depression and anxiety, two conditions which are quite effectively addressed by CBT. Supportive therapy, mindfulness, relaxation, and creative therapies to manage stress. Also, support groups to reduce isolation and stigma. Support groups are also extremely effective for the caregivers and the family members of individuals diagnosed with cancer. Family therapy to strengthen understanding and communication within the family. Psychoeducation to prepare patients for emotional challenges and psychological distress, and in situations where the condition, as you know, two of the most common conditions in the world, depression and anxiety, are also two of the most common conditions diagnosed among cancer patients. When medication is needed to treat severe depression and anxiety, it can also significantly improve treatment outcomes for patients diagnosed with cancer. So thank you very much. That should mark the end of my presentation, of our presentation. Let me hand it back to Zawadi. Over to you, Zawadi.
you very much, Linus. Apologies about the delays in our slides this morning. We were having a bit of a technical glitch. But right now, what I would like us to do, I'd like to introduce Dr. Sylvia Kimotho, who's a consultant psychiatrist and a researcher with special interest in areas that intersect between cancer and mental health. In fact, she's done some fantastic work on the prevalence of depression and caregivers burden amongst family of individuals undergoing cancer at KNH, Kenyatta National Hospital Cancer Treatment Center. So Dr. Kimotho, I'd like to invite you now to take us through some of your insights and inputs on the presentation that you've just had, as well as, a few other things that are of interest before we hear from Mrs. Ruth. Dr. Kimotho, do I have you on call?
Yes, I'm in. Am I audible?
Yes, you are. Yes, you are. So I'd like to first of all just start from where Linus and Vivian have left us, sort of. And I have a question for you. What are the key psychiatric comorbidities or morbidities seen amongst cancer patients and caregivers, and the interventions that Linus was talking about? How do they influence their outcomes and quality of life? Yes, he's given us a bit of a highlight, but can you share a little bit more from your experience as well as from your study?
Thank you. My name is Dr. Kimotho. I conducted my research this year at the Cancer Treatment Center in KNH, and my key areas of interest were prevalence of depression and caregiver burden among caregivers of individuals undergoing cancer treatment at the KNH. And the key psychiatric comorbidities we were able to pick up were anxiety, depression, and we also thought it's a good idea to explore how caregiver burden relates with the depression. So my research findings were that 44% of caregivers of cancer patients experienced moderate depression, and 38% also reported high caregiver burden. And caregiver burden was found to be the strongest independent predictor of depression. This pattern mirrors global findings, showing that 30 to 40% of cancer patients and up to half of their caregivers suffer from clinically significant depressive or anxiety symptoms. These conditions directly impair treatment adherence, pain tolerance, and survival outcomes. Early identification through distress screening tools such as the HADS or the distress thermometer, and routine psychological assessment at key points of care, that is at diagnosis, treatment onset, recurrence, and palliative transition, allow timely intervention. Integrating psychoeducation, brief therapy, and where necessary, pharmacological support within oncology teams improves treatment continuity, coping capacity, and patient caregiver well-being.
Now, it's interesting that you've just spoken about pharmacotherapy, because that becomes my next question to you. What factors should psychiatrists consider when prescribing psychotropic medication for patients undergoing cancer treatment, bearing in mind that they already have a lot of pharmacological interventions in the course of their treatment and care?
Okay, thank you for that question, Zawadi. Psychopharmacological care in oncology, and now with its intersection with psychiatry, must balance efficacy, tolerability, and safety amid complex medical regimens. Antidepressants, SSRIs such as sertraline or escitalopram, are effective for cancer-related depression. However, paroxetine and fluoxetine, which inhibit CYP2D6 and can reduce tamoxifen effectiveness in breast cancer patients. So those ones would be avoided in a patient who is on tamoxifen. In terms of anxiety, short-term benzodiazepines may ease acute anxiety, procedural distress, or insomnia, but require caution to avoid dependence. Antipsychotic agents, they are typical agents like olanzapine, quetiapine, can be used to manage delirium, chemotherapy-induced nausea, and sleep problems, but they warrant metabolic monitoring. Pain and mood overlap, duloxetine provides dual benefit for neuropathic pain and depression. Whenever possible, medication should be combined with psychological interventions. Also, coordination with oncologists ensures awareness of drug-to-drug interactions, hepatic or renal status, and chemotherapy side effects. So this will help in optimizing safety and the quality of care.
Thank you very much, Dr. Kimodo. I'd like to hold you at this moment. I know you have a lot of other fantastic insights to share with us, but I'd like now to introduce our fourth speaker, who has over 25 years as a clinical psychologist dedicated towards palliative and mental health service delivery. She has served in various leadership and clinical capacities and has worked quite a lot in the hospice and palliative care intersects. She's equally a member of the Kenya Hospice and Palliative Care Association and continues to champion for collaboration for the collaboration and compassion, as well as contexts relevant models of care for people affected by chronic and life-limiting conditions. And at this juncture, I'd like to invite you, Mrs. Ruth, so that you can give us your insights, because this is an area that I think you have quite a wealth of experience on.
Thank you so much, Ms. Zawadi, and I'd like to thank my colleagues also and those who are listening. Thank you, Zawadi, and the rest of the team for the I'm humbled to be here today. My colleagues, they've covered so much that I'll just in sum, I love about the research. There's limited research here now in Kenya on the mental health aspect, and I'd just like I'd like to point you to a paper that was written by Ndete, Professor Ndete, Msimi, Tele, Musau, Kitonga, and Mutiso of 2018, that also indicated a high prevalence of depression, 44%, and anxiety, 69.2%. And in my own research, this was among the papers that that I found very, very valuable, in that they report that the psychosocial issues experienced by cancer patients in Kenya could be really going unrecognized, untreated, and therefore unsupported in oncology care settings. So that is something that is very key, that ought to be very key to us, even as I follow on in what my colleagues have already mentioned. To my understanding, the adjustment, the psychological part of it, the physical part, which they have already mentioned, emotional, the practical with finances, childcare, housekeeping, the legal. And then there is the social aspect, of which my colleagues have also touched on, the family relationships and the dynamics. If there are children involved, it means dynamics of school, of work. And then there is the big one also in Kenya, which is the spiritual aspect, where patients and caregivers will now ask themselves the meaning of life in their suffering and in their pain. And then there is the informational, which is, as we all know, most of our physicians or our patients go through a myriad of, from health centers to the main tertiary hospitals, or where they can find care in Kenya, which is really a problem. And that also speaks to the mental health. Most patients, in my experience, even working at hospice and among the doctors, the physicians here in Kenya do not know actually where to go. So in the informational aspect is also very, very important, as patients and caregivers try to adjust to their diagnosis or whatever they may be going through, pre-treatment, treatment, post-treatment, and survivorship, in their journey. And then that speaks, if we could just look very, very briefly through the lens of the biopsychosocial model, which Vivian mentioned about the biological factors. This includes the disease burden, the treatment modality, maybe the neurobiological changes and the stress the patient could experience. So the biological influences in relation to the supportive care needs or the mental health aspect could include the genetic makeup and the history of the physical trauma or disease stage in cancer patients. And then there is the psychological component, of course, which include the patient's cognition, marked by the negative views of self, changes in the physical and role functioning, a loss of control, and uncertainty of the future, the fear, as my colleagues have already mentioned. And then there's the social factors, both related to the role changes. This is for the patient and caregivers. There are many reports, articles, some of them that are unpublished in my view, and experience from my own research with the patients and interaction with doctors, where we find in Kenya the caregivers are their children, who are looking after their mothers or grandparents, or now the role changes in where spouses, where a woman, a lady has got cancer, is being looked after by only the male person. Maybe their children are not there, or the dynamics are difficult. So there's an increased also dependency not only on the lay service, the lay caregivers, but also a dependency on service providers, in my experience, whereby we know that doctors' clinics are full, where there is and the physicians are not able to give that information. So that is also very, very important. The adjustment also, in my view, is based on many, many variables such as age, religion, whatever the cancer stage, the cancer type and its subtypes, and speaking to palliative care, as it were. In Kenya, that is a new approach of care. We all know it's a broad-based, person-centered, multidisciplinary, multi-agency approach to caring for patients with not only cancer, but anybody with life-limiting illness. But it is most of according to my research, which I've done, in another paper with physicians' attitudes to palliative care, there is a lot more that needs to be done in the context of awareness. And as Linus also touched on and spoke to us about not only awareness, but the screening aspect. Most of our patients here in Kenya, and that is recorded, actually present in the clinics in advanced stages of their disease. And that is where there is a problem. So advanced stages of disease, there are findings that, as we all know, Kenyans, this where people feel that even with the advanced stage, they need to do something. So that also adds or speaks to the mental health and all the areas that my colleagues have spoken. So in palliative care, there needs to be awareness, in my view, and because not only the clinical side of it, but to be able to understand the social environment, which refers or speaks to the complex relationships of the individual, that is the patient, and also the caregivers, the family, the service providers, and everybody, because cancer does not, once there is a patient, the whole family, extended family, service providers, lay, this is the physicians, the nurses, everybody. But in palliative care, and in my experience, experience and in my research, we do not understand, I would agree with my colleagues, that there is a lot of work that needs to be done in relation to the mental health aspect of helping patients adjust to their pain. So I was just trying to not repeat what my colleagues have already done. So I hope that is something that we can go on as I hand over back to you, Zawadi.
Before you, like sip some water or take a breath, I'd like to ask you a question.
Yes.
What is the place of faith in enhancing patient and caregiver resilience? And by faith here, I'm talking about, any form of faith, be it, religion, traditional, just the role of faith in all of this.
The role of faith or spirituality, as it is really key, and is often overlooked. As we all know, in the context of Kenya, a lot of us are very religious or spiritual. Religion, of course, there's a difference between religion and spirituality. So when we speak about faith, we're talking about maybe Muslims and their faith. We've seen, in my experience, they have their own ways of coping or adjusting. And there is that aspect of, the patient is going to get well. And that is the same for Christians all over. Of course, for some Christians, they are denominations or sects that do not believe in treatment. And in my experience, we've seen patients actually suffering so much, and their caregivers. And this, for example, are those that like the Jehovah Witness, who will not have blood transfusions or anything to do with treatment. In my experience, faith, is important, and that is what keeps some people going. They'll just, once we have the therapies or some of the therapies, or they want to go for the curative, pushing for that there is something that you can do. But there is also, to some degree, a percentage, this is not, there's no research on this, where also the faith-based, some of the faith-based sects will say God will heal, and God is there, and people believe. But at the moment, but there is also a lot of them who will say, why is this? And that is where the existential or the meaning of life comes in. Why me? And that is something that we as mental health providers is something to explore further and research in a way to help, so that it is a side-by-side therapy, as it were, or an intervention. Thank you.
Thank you very much, Mrs. Ruth. Now I want to bring back Dr. Kimoto. I hope you're still with us.
Yes, I am.
Yeah. So now I want to ask you a question around something that Mrs. Ruth has spoken about quite a number of times, and this is caregivers and just the toll that taking care of someone who has a terminal illness takes on them. So what does evidence tell us about caregivers' burden, and how can we help them so that they can help the people they're caring for?
All right, thank you, Zawadi, for that question. In my KNH study, which I conducted this year, I found that caregiver was the single most significant predictor of depression among family caregivers, independent of age, income, or patient clinical factors. Those with no to mild burden of care were over 3 times more likely to be free of depression. So there was a direct association between how much caregiver burden someone had according to how depressed they were. This underscores the stress process model, where primary stressors, which is care demands, and secondary role strains, which are financial pressure, time loss, erode coping capacity, leading to affective symptoms. Protective strategies include routine mental health screening for caregivers alongside patients, psychoeducation and training on coping strategies early in the treatment journey, structured respite programs, which is temporary relief for the primary caregivers, and support groups to reduce isolation. Also, collaborative care frameworks, bringing together psychiatrists, psychologists, social workers, and oncology teams. Supporting caregivers is not only ethical, it directly enhances patient adherence, emotional stability, and overall family resilience.
Thank you
Thank you,
so
Zawadi.
much. Thank you. Thank you so much, Dr. Kimoto, for very strong statements. Like, we can literally feel the strength in the statements and very true insights in this conversation, as well as in this topic. Now, I'd like to bring back Linus and Vivian. You mentioned that it's important to include caregivers in patient therapies and all of that. And the same has been echoed by Dr. Ruth and Dr. Kimotho. So all of these sentiments have been echoed. I don't know what your thoughts are in terms of whether it helps or whether it complicates the process, because sometimes we know that when caregivers are included, it can be a bit complicated. When caregivers are not included, it can be a bit complicated. So part of integrated mental health, in your slides, you had said that it's important to have, like all of these interventions inclusive. What are your thoughts on that? Linus or Vivian, either of you can take it, but equally, I know that Kate is also around and she's one of the team members of the wellness department, so she can equally chime in.
Okay, so maybe I can give a first response. So when it comes to caregiving, especially for cancer patients, you find that there's the issue of dependence on their caregivers. So meaning for some, at some point, maybe they can no longer work, so they have to rely on their caregivers for financial care, as well as just emotional support. So that's just to tell us that family caregivers, as well as family members, do play a crucial role in that particular regard. But also, as Dr. Kimotho has mentioned, we still can't ignore the toll that takes on the caregivers. As she has said, they also get to experience a lot of emotional turmoil, because now they have to consistently show up. If, for instance, I am now looking to someone maybe to ensure that they keep up with my reviews, they keep up with my clinics, they ensure that my medication is taken. I have taken my medication, but at the same time, I still have to perform my roles outside of caregiving. So it brings about the issue of, balancing this new role of caregiving versus what they have already been doing previously.
Thank you very much, Vivian. I don't think anyone would have answered that question as well as you have. Thank you so much. I don't know whether Linus or Katie have anything to add, but I feel like you have quite adequately addressed that question. Now, the question I want to ask next is, we've talked about the caregivers in terms of relatives, family, spouses, but then Mrs. Ruth also mentioned something about over-reliance on the medical fraternity or the staff. And for this one, I'd like to just ask her, a question. How do we help manage burnout and maintain staff well-being while supporting the emotionally demanding cases as well as all of the tasks that come about in palliative care.
Thank you, Zawadi. In my experience, burnout, the only way we can manage burnout, or one of the ways, is first of all to acknowledge that we are burnt out. And just like the people that we are looking after or caring for, is to be able first to acknowledge and also seek help ourselves, which mostly we don't do, because everybody has their role, everybody wants to do something, or help as much as they can. And but it is, in my experience, self-care is so important. And the way to manage it is to first acknowledge it and seek help. Thank you.
Thank you very much. Now, this question, I'd like to send it towards Dr. Kimotho. So now I'd like to ask you, like from your studies and from your experience, what approaches do you find most helpful in helping patients gain a bit of hope and emotional balance, especially in the course of treatment? Because sometimes, hope can be very fleeting when you're dealing with something that is very life-threatening. Dr. Kimotho?
Thank you, Zawadi, for that question. Dealing with patients who have chronic conditions and not only cancer can present a challenge, especially for us who provide psychiatric and psychological care. But I think the main things would be to encourage them, give them something to look forward to, the support they get from their family, friends, and their community. Encourage them about recent developments that could improve their outcomes even by more years that was previously possible, and also encourage them to seek help and lean in on their social support networks as a source of hope. Thank you.
Thank you so much, Dr. Kimotho, for your response. At this juncture, I would like to, sorry, just 1 second. I can see that we still have Dr. Mushiru on the call. Let me just help her get a mic so she can speak and share with us any insights that she has. Let me try and find her. As I'm finding her, maybe I can, still engage you, Dr. Kimotho, for this one. Sometimes it is reported that cancer treatments like chemotherapy, steroids, pain medication, and all of this very life-saving interventions that we now have equally contribute to psychological changes like mood changes, behavior changes. How can we help, patients and families recognize and manage this early in a way that does not compromise their wellness? So this question will go first to you, Dr. Kimotho, and then I'd like Dr. Mrs. Ruth to help support that as I try to find Dr. Mosheru.
Thank you. I think this particularly needs a collaborative approach between us, psychiatrists, psychologists, and oncologists, because they do spend quite a bit of time with cancer patients and caregivers in the course of treatment. And it would be beneficial first for patients to be able to hear from their oncologist any expected side effects of chemotherapy and radiotherapy, especially the mood symptoms, which maybe other professionals may not really take much time to explain to patients. And I would think if there would be like psychologists and psychiatric nurses at the clinics who are able to review the patients frequently as they come for reviews and explain symptoms of chemotherapy, the side effects of chemotherapy and any other mood symptoms the patients would be experiencing, which some could be attributed to medication. I think once the patients are able to understand that these are side effects from treatment, they would be able to understand them better and be able to deal with the symptoms they experience better.
Thank you, Dr. Kimotho. Go ahead, Mrs. Ruth.
I would agree with Daktari. One, I think it was my colleague Linus who said about integrated care. From the outset, I don't know what Dr. Kimotho will say, but about the mental health, or when in my experience at hospice, because I try to, I have an ongoing program there for the patients. Most of the patients were very reluctant to discuss this. And it is because when one speaks about mental health or referral to a facility such as Chiromo, or even KNH, or Madare for assessment, patients or caregivers will tell you, I'm not mad. So that needs to change, and I don't know what maybe something that we've also not touched on is the sexual dysfunction, which significantly impairs the quality of life of cancer patients. Maybe Dr. would say something about that, where clinical practitioners ought to really recognize the importance of addressing sexual concerns and then refer them to the proper channels of how patients and caregivers can be supported in this. And I'm talking about sexual dysfunction because that was something in my experience that I found out even at patients in their survivorship or treatment or post-treatment were really, really, had a lot of questions that had not been answered or responded to, from their oncologists. Thank you.
Thank you very, very much, Mrs. Ruth. And you've also highlighted something that we also hardly ever talk about, which is, when people have cancer and other terminal illnesses, we mostly focus on their mental wellness, their physical wellness, but then we don't look at them holistically into all the things that involve a human being and a human being's different dimensions of life. And I think the point that you raised there around sexuality becomes something that is of concern, especially when we have someone diagnosed when they're very young, when they're just starting out a family, when they don't have children just yet, and they're thinking about all of this. That, of course, doubles the emotional toll and psychological toll that they're dealing with. So thank you for that one. Now, because there's a lot to say and time is really, really on our case, I'd like to invite Dr. Frank Njenga so that he can give us his insights around this very timely yet very sensitive conversation that we're having today. Professor Njenga?
It's a great pity that Dr. Mushero has not been able to join us, because she's regular in these sessions, and I always find her insights very, very helpful. So if you can find her, please do. Happily for everybody, I only have two things that I would like to say. Actually, three. The first one is that this conversation is timely, not only because this is the month of October, but because it confirms what we have said of ourselves in the past, which is that our learning activities have to have relevance to what is going on around ourselves. For example, we have previously held conversations around the Gen Z issues when that was the relevant issue. We have talked about climate change when that was the appropriate conversation at the time. We are now talking about cancer and so on. So our learning, I congratulate you, Zawadi, and your team for continuing to be relevant in the lessons that we are teaching and learning from each other. That's the first thing. And of course, I want to thank all the participants for this morning. Very, very high level of presentation, discussion, and conversation. Now, the second thing I wanted to say is a conversation around which has been brought out very clearly by Dr. Kimotho, that in discussing the mental state of human beings around cancer, there are two basic and almost different human beings. The first one is the patient himself or herself, and around the patient herself or himself are a multiplicity of issues that include the stage of the diagnosis, the type of cancer and the site of the cancer, the level of support they have or don't have, and so on. So that's one key player around whom issues like, for example, the toxicity of the medication they're receiving is crucial. But Dr. Kimotho has raised a separate issue, which is that of the caregiver himself or herself. Because in many instances, the caregiver has also their own multiple issues. For example, the caregiver has to suspend certain aspects of their own lives to be the primary caregiver. And the science around the levels of anxiety and depression around the caregiver is solid. And it's solid particularly around caregiver rates of depression in dementia, in people with strokes, in people with cancer. So the role of caregiver itself causes and creates significantly high risks of depression, anxiety, and other things. So that's the second thing about the distinction between the two separate human beings who are involved in this matter. The third and last thing that I wanted to say is around our own patients that we look after. When you ask ourselves what kills our patients, younger colleagues will jump into the picture and say suicide. And whereas it is true, some of our patients die by suicide, we know that patients, for example, with schizophrenia or psychosis, have their lifespan shortened by up to 20 years, not because they die of suicide, but because of other physical conditions, including higher rates of cancer, higher rates of cardiovascular disease, and so on. So this conversation actually might have held the direction that says effectively that our patients, the ones that we look after for many, many years, have a higher than average likelihood of developing cancer, for example. For example, if you look at the number of patients with whatever psychosis or anxiety or depression who smoke and therefore put themselves at risk of all manner of cancers, lung cancer, bladder cancers, and so on. So this conversation is very important because it helps us to focus on those people that we have been required to look after. So this is a big conversation. I hope it doesn't end at 9:30, which is where I'm about to stop. But Zawadi and your teams, I thank you for bringing together this session about caregivers in general and people who have cancer in particular. Thank you and have a good morning.
Thank you very much, Dr. Njenga, for very, very insightful remarks and comments about this. Some things that I'm sure we hardly ever critically analyze for ourselves. I'd like to give a special thank you to Mrs. Ruth, to Dr. Kimotho, and to the wellness team in particular, Victoria, Linus, Vivian, and Kate. And now I would like to close our conversation for today by thanking all our participants once again and our attendees for today's session. which reminds us that behind every diagnosis, there's a human story that involves courage, vulnerability, and connection. We have seen the intersects of cancer care, and mental health, and how supporting one helps improve the others, and not only just for the patient, but also the treatment outcomes and for family resilience. As we leave this session, I'd like us to just continue thinking that psychological care, mental health care, holistically looking at each and every person who walks into your offices today and for the next couple of weeks is not just a statistic. These people require a lot of holistic and wholesome care for healing. Thank you very much, and welcome again to the next grand round in the next couple of weeks. Asanteni sana.
Thank you. Thank you, Zawadi. Thank you, everybody. Bye.